There's a little bit of overlap, of course, with my talk and the things that you've seen a little bit earlier, but I'm going to review just a little bit of the natural history of Graves' disease as it relates to the eyes and orbits. In about 85% of patients, the signs of eye disease develop within 18 months after diagnosis of a dysthyroid state, like Dr. Kahana had mentioned. However, the onset of eye disease can be rather unpredictable, and when there are outliers, we really mean there are outliers. There are people who go for decades with no problems after being on thyroid replacement therapy, and suddenly their eyes change. And vice versa. Some people immediately at the time of diagnosis, the first symptom that they have is that their eyes have changed in appearance, and that's what brought them to the doctor in the first place. So being so unpredictable, it then becomes challenging to figure out exactly how to best help a person, especially at the first encounter. And so we're going to go into a little bit of detail about how we try to optimize that for our patient population. You know, the disease is usually progressive in its initial course, and it may have a fluctuating course. So just because it's getting better one week doesn't mean that it won't bounce back the next. And I'm sure a lot of people here are all too familiar with that. So when you look at Graves' disease from a little bit of a long-distance perspective, there's something called Randalls Curve, which basically explains the course of the disease. If you take time on the bottom axis and severity on the vertical axis, usually people will ramp up to a very high inflammatory state, and that will slowly burn itself out. And that timeline can be different for different people, but roughly it's in the order of several years. So the treatment algorithm for an individual patient depends on where along that curve you are at the time that you encounter your physician. So one of the first things that we have to do is stage the disease. Are you in the active inflammatory portion, or have you already gone through that, and are you in your stable portion? Once we figure that out, then that helps us figure out how we can best help you. If you happen to be in the inflammatory portion, that's usually the most uncomfortable and the most challenging. And so there are a number of treatment modalities that can be given to treat that, including steroids, radiotherapy, and some others which I will touch upon. Once that's done and you're in the chronic phase of the disease, then people start having surgical interventions, whether they need it for compressive optic neuropathy or for the positions of the lids, etc. And Dr. Douglas is going to get into a little bit more detail about that. I'm going to be talking a little bit about the first two. So I want to take a step back and talk with you about how we do this at the Kellogg Eye Center. And I just joined there about 4 months ago as a fellow, and I've had the distinct honor of training with Dr. Kahana and Dr. Douglas and these really wonderful people who have quite a bit of experience doing this. And I've been very impressed with the way that they do things, and so I'll walk you through it. You know, usually when there is a new patient who's coming with Graves' disease, all sorts of bells fly off in the office because Graves' disease patients are very special patients. So I hear about them weeks before they arrive. Our secretary gives the patient a call, asks them what's going on. What brought you to your first doctor? Why did you get referred over here? How are you feeling? Are you having double vision? How's your thyroid level? Is there any way you can get us your records? Can you send us your pictures, your images, whatever? We try to collect as much as we can, and she then hands those to me. And so I have this stack about yay big for each patient before they come, and then I call the patient, and I say, I know that you already went through this ridiculous interview with our secretary, but I want to interview you too, and this is why. And it's because I want to make sure that I'm prepared before you come to see me to make sure that I can help you in the best way that I can, and that Dr. Douglas can, and that all the other people at the Kellogg Eye Center can, should it be necessary. Dr. Kahana touched briefly upon the fact that we have a multidisciplinary thyroid clinic and discussion group. We meet monthly and we discuss all of our patients with surgeons, with endocrinologists, with pediatricians, with pediatric ophthalmologists, and all sorts of other subspecialists and researchers in a way that we can try to optimize the treatment for that particular person. We put together slides, we show everybody's pictures, and we actually come up with a treatment plan at the end of that meeting and send it both to the patients and to the referring physician. This sounds like overkill, but it's not. And the reason is because, as I'm sure many of you are aware, the first visit to an ophthalmologist or to any kind of Graves' disease specialist can be a marathon. You know, you're there for hours, and it's very frustrating, and it takes a really long time, and they make you do really uncomfortable things like visual fields and all this stuff. So I want to make sure before I put you through all that, that A, we need to, and that B, we can do it in the most efficient way possible. So sometimes it involves me arranging visits with the pediatric specialist, not because the person is a child, but because they're the ones who deal with alignment of the eyes. So if I know they have double vision, I know that'll be necessary. So we make the appointment at the same time. If they don't have an endocrinologist and they're looking for one, we get them one. And so that way, on that one day, you can run the whole gamut, and thereafter the plan becomes a lot more smooth to actually implement. And once you get there, of course, you have your clinical exam and all the ancillary testing that's necessary, and that's how we come up with a treatment plan for you. We document it, we send it in a letter, and everybody's on the same page. So As part of that treatment algorithm, there are a lot of things that can happen involving ophthalmology and as well as a bunch of other departments. So I'm going to focus now on the ophthalmology side of things. So where on earth do steroids and radiation fit into this curve, this magical curve that I told you about? Well, turns out that it's really at the hump. That's really where the steroids and the radiation, not radiation for the thyroid, but radiation for the orbit, actually radiating the actual eye socket. This is the area where it can actually be useful. And this is the peak of the inflammatory phase. The idea of putting people through this, either a course of steroids or radiation to their orbit, is in an effort to achieve this. We'd like to take that curve and change it so that it doesn't go as high and doesn't last as long. Now, there's no proof out there in the literature that says that using the steroids actually achieves this, meaning the shortening of the curve. But anecdotally, we see that people tend to do a lot better if you can control their inflammation acutely. They're a lot more comfortable, they're a lot happier. And our hope is that at the same time, we're actually shortening the duration of the time they have to suffer through that hump of the inflammatory process. And so, the question is, well, do they really work? What is it that you're actually achieving by putting people through these steroids that have a lot of side effects and are sometimes rather uncomfortable to take? So before we delve more deeply into that, I want to just go over, well, what are the options for treating that inflammatory hump in that curve that we discussed? So we mentioned that steroids and radiation are two of the options. There's also selenium, which I know that's been touched upon earlier today. And there's also another whole litany of cytotoxic agents. And what does cytotoxic agent mean? Well, there are ways to actually specifically target portions of the immune system and knock them down in an effort to specifically address the Graves issues without making the person susceptible to other infections, etc. And we'll touch upon those briefly as well. So back to the steroids. They're typically given by mouth or in an IV. And less commonly, they can also be given locally as an injection directly into the eye socket. And so what are the pros and cons of doing each of those types of treatment regimens? Well, oral steroids are probably the easiest. You can do them at home. You can take a calendar with you with your pills, and you know how many to take on each day, and it's very easy. The access to these medications is very easy. They're available at any pharmacy, including the drugstore pharmacy, and they're effective. We know that they make people feel better. The cons of oral steroids is, well, I'm sure anybody who's been on them knows that they have quite a few side effects. They can make you restless and not sleep well. They can affect blood sugar. They can induce weight gain. They can change the fat distribution in the body. And they can knock down your immune system. A steroid is like a really big gun aimed at your immune system. It shoots everything down. And so it makes it possible for you to get other infections, get colds, etc. If you're on steroids for a long time, it can thin your bones. And it can do all sorts of things like that that can be rather unfortunate if the person is on steroid dosing for a very long time. So in an effort to ameliorate that, we try to give steroids in as short of doses as possible. And sometimes doing them intravenously allows us to do that. So it has been studied. There have been people who have looked at giving people IV steroids versus oral steroids as far as how effective they are in controlling the Graves symptoms and how damaging they are in terms of side effects. It turns out that intravenous steroids actually have a much more favorable side effect profile. The likelihood that you would get, for example, liver toxicity from an IV steroid versus an oral is lower. Usually, the changes in blood sugar are minimized. And usually, the weight gain, etc., is also minimized because the IV steroids are typically given for a shorter duration of time before you get your desired result. The cons really, in addition to the fact that they can still have some of the side effects, although they aren't minimized, is access. You have to go somewhere to get the IV steroids given. You can't just pick them up at the pharmacy. At the Kellogg Eye Center, we have people coming to see us from 6, 7 hours away, typically on any given day. And the idea of having to commute that far to get your medication is really, frankly, impossible for some people. And so these are considerations that we have to take into account when deciding a treatment plan for a person. And then, of course, there's local injection. Yes? So usually it's a few days of, and then depending on, you can dose them in several ways, but typically you get a couple of IV shots per day, and then they're dosed over 3 to 4 days, and then you have an oral taper after that. So usually you end up on a little bit of oral even when you get the IV, but the total duration of treatment is much shorter. It turns out to, maybe less than half the time, versus the oral steroids where you start with a fairly high dose, you have to be on for at least a week, and that's if you're doing a fairly rapid taper, sometimes more than that, and then you go down very slowly thereafter. Local injection is usually a one-time deal that then may be repeated about 6 weeks later. It's actually a needle in your eye socket. So some people, that makes them a little bit uncomfortable, but usually goes really well. The issue, of course, is that you're you're not targeting the entire immune system. You're just trying to target the tissue immediately in the area that's affected. And so, anecdotally, people who have done this have had mixed success. Some people say, this is just wonderful, it's great, my patient is so happy. Some people say, not only did it not work, but it gave my patient high pressure, now they have glaucoma, and they have issues with softening of their eye tissues, which can happen. It really hasn't been studied rigorously enough for us to make any definitive recommendations about it. But there are some people who are too sick to have systemic steroids, and frankly, that becomes one of the only options that's left. So by knowing your full medical history, we can really come up with what's most reasonable to offer the patient. The cons I already referred to, which are that you can have localized ophthalmic effects from the steroid, one of the most important of which being an elevation in eye pressure, which can affect vision. Orbital radiotherapy. So orbital radiotherapy turns out to be actually fairly controversial. It's given by radiation oncologists. They aim a big beam at your face in the area of your orbit that's affected. They shoot you with some radiation, and the idea is that it actually helps to resolve some of the inflammation and fibrosis that's going on. It turns out it works, but the catch is that it works in people who are responsive to steroids. So in people who are responsive to steroids, you've probably already tried that. So then the people who end up actually needing radiation therapy by itself is rather small. It's an adjuvant to steroid therapy in our practice. This varies from country to country and from region to region, but we don't use it that often, actually. In the studies that have been done on the use of radiation, oftentimes it's been done in conjunction with steroids. So again, these are patients who respond to steroids, and they're hoping to get an additional benefit from having radiation. And there's been reported some effects on strabismus, meaning some correction of the double vision, about 8 degrees of correction in those people, as well as a little bit of improvement of the proptosis, about 1 millimeter or so. In people who have very severe disease, that it's like spitting in the ocean. In people who have milder disease, maybe that's helpful. So you have to really, again, weigh where the person is on that curve and figure out if this makes sense for that particular instance. So what I've talked about thus far is steroids and radiation, both of which are fairly big gun treatments, and they make a lot of sense in people who are just hot, hot, hot in terms of their active inflammation. They're at the peak of that curve, they're miserable, they can't sleep, and so you want to do anything that you can to help them. What about early and mild disease, though? Somebody comes in whose eyes are a little bit open, maybe they have some dry eyes that's fairly well controlled with their drops, they're worried about what may happen later, but you don't find that they're necessarily doing badly enough to put them at risk by putting them on steroids or by doing something that's that severe. Well, it turns out that this patient population is the one that may be helped by selenium, which I know Dr. Smith spoke about briefly. So just very quickly, we'll go through it. This is a dietary supplement. It's a trace mineral that's been found to be immunomodulatory. So what does that mean? Well, it means that in a sense it does what steroids do, just in a much smaller way. It takes your immune system and it tweaks it. And the idea is that you want to tweak it in your favor so that it's not hyperactive and it's not attacking your own tissues. There are geographic areas around the world of relative selenium deficiency. We are not one of them. We have plenty of selenium in our soil, so usually most people in this room are probably not selenium deficient. If you go to China, it's a different story. And so this is being studied very actively right now throughout the world. And anecdotally, for people who live in areas where there isn't a lot of this trace element around, supplementing it seems to help them. But it's really unclear whether this is the case for us here. The improvements that people have found with this are really quality of life based. These are based on survey implements that they give to these patients who are mild. They said, well, now you've taken selenium for several weeks. Can you please answer this litany of questions about how you're doing? And they found, with statistical analysis, that some of these people really, in fact, do get better. They have soft tissue findings are primarily the ones, so the swelling of the lids tends to go down. They tend to be a little less red, and they tend to be a little less uncomfortable. So the risks, there's one study that was done with selenium which was actually prematurely stopped because of an increased risk of converting to a type 2 diabetic. This was only seen in that study, not in others. And so our feeling is that it's probably fairly safe. But again, that's another point of controversy that requires further study. The bottom line of selenium is that it appears reasonably safe, and it's good for that tiny demographic of people who are just a little bit uncomfortable, but not uncomfortable enough that you're willing to risk steroids. I have a feeling that a lot of you here are probably not in that group, but some of you may be, and so this is something that you may want to talk to your provider about. Okay, so we talked about people who are severe, who are candidates for steroids and radiation. You give them steroids and radiation. We talked about people who are mild, who you don't want to do that with. You consider selenium and supportive therapy like dry eye therapy and what Dr. Kahana was talking about. So what about the other people who are very sick but aren't candidates for radiation or steroids for some reason. They're too ill, they can't handle the therapy because their comorbidities are too high, they're already a diabetic and their sugars are all over the place. What do you do? So this is where there's a new horizon in therapies for Graves' disease that's being developed and being researched very actively at Kellogg. And I'm very, very grateful for people like Dr. Miller and Dr. Douglas who work together on all facets of this, actually, from the surgical standpoint, from the immunological standpoint, to try to come up with answers as to how we can do this in a more efficient and effective way. So I'm going to take a step back and talk about a little bit of the mechanisms behind Graves. So what you're looking at here between the red lines is supposed to be a blood vessel. And those little things that are floating in it are blood cells that are producing deranged antibodies. So these deranged antibodies then go and attack different tissues throughout your body, on your skin, on your eyes, and on your thyroid. So, and also in the joints, it turns out. So there's a lot of kind of overlap between rheumatologic diseases and thyroid eye disease, as has been alluded to earlier. So what the idea is if you can somehow prevent these cells from producing these deranged antibodies, or alternatively, prevent these deranged antibodies from getting to their eventual targets, then maybe you can stop the effects of those deranged antibodies and prevent the development of the Graves' disease, or improve it if it's already been happening. So there are some T cell and B cell antibodies that exist out there that are actually currently being studied actively in humans for precisely this reason. So we'll go into that. This slide here just shows basically how a B cell is born and how it grows up to become mature. And these B cells on their surface produce all of these little markers that your immune system uses for signaling. It's like going through a highway system and having the right easy pass or fast pass, whatever you call it in New England, to get through the toll. Well, if you have the right marker, you can make it through. If you have the right marker and your antibody happens to like that marker, then that cell can get deranged. So it turns out there's one particular marker called CD20 that's present in a lot of the steps that a B cell has to go through before it becomes a mature B cell. And so there are people out there who are very smart who basically decided to target CD20 and see if we block CD20, can that then prevent this immune reaction. And there's medication out there called rituximab that does precisely that. And there have been several patient groups that have been studied doing precisely this, people who have not had good responses to other therapies, who have then been treated with rituximab. And this was one study that had a small set of groups, but even in the small set of group, the results were statistically significant. There are people who had failed steroids, and after rituximab, 2 months, and I think the ultimate follow-up was about 1.5 years, had actually had a tremendous improvement in their clinical activity score. I don't know how many of you are familiar with the clinical activity score, but it's basically a lump sum of all of the effects of thyroid eye disease. The redness, the swelling, the bulging of the eyes, and etc. You take that all, you put it into one score, you measure them before the rituximab, you measure them after, and they did okay. So this is one area that's particularly exciting because it's offering basically a new way of treating people who may not be candidates for the conventional therapies that are out there. This is just one patient that was in our clinic who was precisely in that position. She had a lot of other things going on in her health. She couldn't really be on steroids. They tried rituximab, and she was very happy. Now, as you can tell, she does have strabismus. Turns out the strabismus was there to begin with, and that's been part of her natural course. She'll eventually need strabismus surgery, but in the meantime, at least, she's comfortable. And so this is someone who is very happy with her result. So what else? Besides treating of B cells with this rituximab, well, there's another immune marker called insulin growth-like factor receptor, IGF-1R, which has been isolated on fibroblasts. Now, why do we care about fibroblasts? Fibroblasts just happens to be one type of cell that's in connective tissue. There's really nothing particularly special about it, except that they're the ones that misbehave in Graves' disease. Your muscles get really fat and stiff because fibroblasts are doing crazy things. The eyes protrude because fibroblasts are doing crazy things, and they're making the fat hypertrophy and is pushing everything forward. It turns out it's really one of the main things that goes wrong in Graves' disease, so it makes sense that it's something that we should study as a potential target to help people feel better. So it turns out these fibroblasts have this growth factor receptor on their surface. And much like we explained with the B cells, you can fashion a blocking antibody, basically that you make in a lab. You can give it to the person intravenously, and basically it'll make those little receptors invisible to your immune system. It just coats them so that your own immune system can't activate them and make them do their deranged things. And so there's been a lot of really promising work that's been done in tissue culture with this particular type of treatment, but we're still a little bit ways away from having it be available clinically. But this is the type of work that we're doing at Kellogg, and we're really hoping that we can really achieve something wonderful with it. Because if you can somehow change the immune system in a way that only targets the part that's deranged, then you're minimizing the side effects and hopefully increasing the effectiveness of your therapy. And that's ultimately our goal. So where are we looking to in order to find these targets? Well, we're looking to basically our colleagues. You know, we have rheumatologists, we have endocrinologists that come to our meetings, and we talk all the time. And it's precisely for this reason, because they say, wait a minute, in rheumatoid arthritis, this is what we do, and this is why. And it turns out that there are a lot more similarities between the two disease processes than we initially thought. And this is turning out to be really awesome and exciting. So we hope that it really works that well. So in summary, you know, again, the most important part is the stage of the disease. This is why we go through so much trouble ahead of time before people come to see us. We just bombard them with phone calls and ask them all sorts of really annoying questions. But there's a method to the madness, and the reason is because we want to make sure that we don't waste your time, and we want to make sure that we get you better as quickly as possible. Once we figure out where on that curve you are, then we can start talking about tailoring therapy for you. And if you happen to be in the inflammatory phase, then you fall into one of those categories where either we just watch you, we treat your dry eyes and do nothing, you may be the type of person that's motivated to do selenium, or you may be bad enough that you need radiation or steroids. And you know, that's the type of thing that you have to have a conversation with your provider and say, well, what really are the side effects? Am I willing to deal with the potential side effects of this? Or is this going to really interfere with my quality of life? And that's a conversation that has to be very complete and has to be very honest, because otherwise you won't end up happy. And you know, for people for whom that's no longer an option, then we have these new frontiers that we're hoping will really be available soon, because I think it's a very exciting field. So after all that is done and people have reached their kind of chronic phase of their disease, then is when you really start moving into the surgical aspect of things. And so actually this will segue nicely into what Dr. Douglas will talk about, because he'll directly address, you know, what we do surgically to help people to feel better in that regard. I'm going to stop my comments there in the interest of time, but I'll take any questions that you may have. Yes? For the selenium, you know, actually, I don't remember off the top of my head. I'd have to look it up. I think you're absolutely right. Yeah. Right. Right. Yeah. Yeah. Mm-hmm. Wonderful. Yeah. Yeah, that's fantastic. And that's, you know, and that's just it. You know, you probably fell in that range of people that really can benefit from this. And so that's why it's so important to really stage properly ahead of time. Anyone else? It, yeah. Mm-hmm. That's wonderful. Yeah, but any little bit helps, right? Yeah. Of selenium?
Yeah, in other words, can you only use it for so many months, years, whatever, before any kind of more damage could be done?
Well, so the main risk factor that people worry about is this, that stopped that other study regarding the development of type 2 diabetes. But it turns out actually it's a trace mineral that we all kind of consume in pretty significant quantities all the time. I don't know that anyone's looked at that question in particular, though, to be honest. It's a fairly recent development.
At the higher dose,
Right.
it was stopped, but at a lower dose,
Right.
is there still the same risk?
I don't think it's been seen yet, but we have to continue to monitor it to make sure, obviously. Yeah.
At the lower dose, there's been no evidence
Yeah.
of increased risk. And the other aspect is that since these are trace minerals, they're actually not approved by the FDA and the only
Yeah.
so there's actually no long-term studies about
Right.
implementation. The way the
Yes.
So would you recommend just taking it for 6 months then, and then stopping?
Well,
I usually do this because I don't have a clear idea of what it's going to be doing long term. And in 6 months, you'll get an idea whether
Right.
it's actually helping you or not.
right. Yeah. Yeah. It's like- Well, I don't know about that. I mean, I think the idea is that it's immunomodulatory, so presumably you would take it if you feel like there's some sort of immune issue. But like Dr. Douglas said, I mean, by 6 months you would know. And then there's some people that said, well, I feel so great, I really don't feel comfortable being off of it. And there are some people that say, well, you know, I just don't feel comfortable being on a medication if I don't have to be, so let's try being off. And that's, again, where you have to have the discussion, because the data just doesn't exist. So you have to be, you have to realize that you're taking a risk. I think it's a small one, but it is a risk nonetheless. Yeah. Mm-hmm. Right. I always think of those drops as being cosmetic. So the thing about them is that the way that they do what they do is they constrict your blood vessels, and so in a way it kind of stops the normal flow of nutrients to the area. And also they have a tremendous amount of preservatives in them, which can ultimately be very, very caustic if you use them with regularity. So I tell people, if you have to go to the opera and you want to look really nice for your pictures and you happen to have red eyes that day, go for it. but I don't think it's actually a good idea to use them with any regularity, because the formulation is not really a lubricating formulation. It's really you're masking what's going on. It's like putting mascara or putting cover-up over, it's not getting rid of the problem. And I think that, in fact, it can be creating a problem because you have so many preservatives in there which are just not friendly to the eye surface. Oh, listen, I understand. I'm a plastic surgeon. I get it. but you just, and that's why I think judicious use is good, but you have to be very careful. Yeah. Yes.
Are there any recommendations about contact lenses, either before disease and mild disease? Is it not recommended? Is it a big difference?
So that, again, becomes a very individual kind of issue, and the reason is this. So contact lens wear, especially of soft contact lenses, can really exacerbate dry eyes, and it can limit the amount of oxygen that comes to your cornea. It turns out that the way that our cornea breathes, which is where the contact lens sits, is a lot of that air just comes from the environment. And so you are, in fact, kind of choking off some of the oxygen supply to your cornea, and you're, in fact, drying it out a little bit extra by putting a contact lens in. It becomes a matter of tolerance. If you're wearing contact lenses, you have to know that you're probably going to need to use your tears more often. And if you can strike a balance that keeps you comfortable and that your ophthalmologist says is not, destroying the ocular surface, then you're okay.
I'd like to take one more question of it,
Yeah.
Dr. Douglas.
Oh, sure thing. Yeah. I hope that was an answer to your question. Okay. It's basic. The rigid lenses dry out less, actually. Yeah. They're just a little harder to get used to. But if you can tolerate them, then more power to you. Yeah. They do very well. Yeah. Yes? Indirectly, there can be, but typically in extreme cases. So, for instance, if you have a lot of congestion in your orbit, meaning that you have tight, bulgy eyes that are very tight and a lot of redness and congestion, then sometimes the blood that's around the eye has a hard time draining out, and that can actually increase the pressure in your eye. There was one case that we had in June of a woman who had very, very bad glaucoma that was very poorly controlled even after glaucoma surgery, and she happened to also have Graves' disease, and we did a decompression for her, both to help her proptosis, and her ocular pressure came down 5 points the day after the surgery, just because there was more room in her orbit. So, but that's a very unusual circumstance. And then the other circumstances where we discussed, for example, giving steroids locally, the steroid itself can then increase the pressure and then lead to a secondary glaucoma. But in and of itself, having Graves' disease is not really related to glaucoma. It's only as a secondary effect. Yeah. Okay. Thank you so much. Yeah.